Well, it's 5 o'clock now. Hello, everybody. Good afternoon, and welcome to the EANS webinar on spinal cord injury. It's a great pleasure to start and to introduce. My name is Andreas Unterberg. I'm Chair and Director of the Department of Neurosurgery in Heidelberg, in Germany. And I have been told by Anna from the EANS office in Brussels that there is a great interest of many of you to listen to the upcoming and following presentations by 3 speakers. And we would like to give you an update on surgical, medical, and experimental treatment of spinal cord injury. The 3 speakers will be Bassem Ishak. He is a young, fully trained neurosurgeon from Heidelberg. The second one will be Professor Weidner. He's a neurologist and chairing and directing the Department of Paraplegiology in the Department of Orthopedics and Trauma Surgery in Heidelberg. And the third speaker will be Alexander Junzi. He is also a young neurosurgeon interested in spinal cord and cerebral trauma. And we will start with Bassem Ishak. He will talk about the surgical perspectives. Dr. Ishak trained in Heidelberg, and after completion of his training, he went to Seattle, joining Professor Chapman as the Swedish Institute for clinical and experimental research on spine. And now he came back, did his habilitation in German, which is corresponding to the PhD in Europe, and is now guiding the section on spine surgery in our department here in Heidelberg. Now, Dr. Ishak, it's all yours. You should talk about surgical treatment, the actual update. Of course, spinal cord injury is the main topic. It's all yours now.
Thank you, Professor Underberg, for this very kind introduction and a cordial welcome to all participants and listeners. The EANS is a great and a huge platform. It's always a big pleasure to present and to give a good presentation. So on my part, it's the surgical treatment of SCI. So, and before we start with the surgical things you're all interested in, we please go through a few slides of epistemology.
Excuse me. I apologize to interrupt. And this is just for a technical note, a remark. I got it on my paper here because I was told to tell the listeners and joiners of our webinar that there is, of course, time for questions and discussion. And please write your questions in the Q&A section, and then we will be able to look it up and to answer your questions, hopefully quickly, and don't use the chat. The chat will only be used for informal technical purposes. So I apologize again and again. Dr. Ishak starts on surgical treatment of spinal cord injury.
Thank you very much. So as we mentioned and said before, we just want to give a few slides about epidemiology. I don't want to bore you, but some things are a kind of interest. The typical SCI patient today is a male patient, over 80%. We know this from recently published studies. They are in their mid-40s, and we will listen later on, and we'll know that patients, for instance, with ankylosing spondylitis who have SCI are older aged. It's often a vehicle crash, and with almost 40% and almost 1/3 is falls, can either be a simple fall or fall downstairs or fall from ladders. And cervical spine is most often involved in over 50%, but take in mind that we do not want to miss out the thoracolumbar SCI, and most often incomplete tetraplegia or paraplegia occurs. But we have the Asia Impairment Scale, which is validated, and this is, I think, a great tool to have. But before we want to talk about surgery or great surgical procedures, we just need to know that we always need a first-line care, because we know from guidelines, and they are almost published in 2013, that we have always to secure the airway, breathing, circulation, and of course the spinal immobilization. We have to give large volume intravenous fluid therapy. And what we also have to take in mind is that during the acute injury, systemic hypertension below 90 millimeter mercury is associated with worse neurologic outcomes. Early imaging, of course, using CT or MRI scans, which are available 24/7, and ICU management. And what do we do on this ICU when the patient arrives? We always monitor the respiratory, hemodynamic, and cardiac function. We have to maintain adequate spinal cord perfusion. We have to have mean arterial pressure above 85 to 90 millimeters mercury post-injury, because this has shown an improvement in ASIA grade of at least 1 grade for patients for the first 7 days post-injury. Of course, oxygen saturation should be maintained above 90%. And of course, the venous thrombosis prophylaxis should be administered as soon as possible. And just again, just 1 or 2 slides, just why ICU? Because we know from the literature that incidence of hypotension after cervical STI at arrival to the emergency department is 25.8%. And the incidence of a typical neurogenic shock was 19.3%. And cardiovascular disturbances are the leading causes of morbidity and mortality in both acute and chronic phases of STI. And the impairment of autonomic nervous control systems in patients with high STI, cervical or high thoracic, causes cardiac dysrhythmias. So, and what we always want to know and what we ask for is, what about cortisone or mature prednisolone? And we know from a recently published study in 2017 that a high dose of 24-hour regime of MPSS confers a small positive benefit of long-term motor recovery when administered within 8 hours of injury. But on the other hand, the decision not to use high-dose MPSS for treatment of a specific spinal cord injury cannot be interpreted as lack of treatment. Between us, to administer cortisone or prednisolone in a young patient, I've never seen one who died due to pneumonia. So, I mean, you can take this in mind, but we don't have evidence for that. And then time at spine, I think this is the main goal we have to know, and we have to take into account early decompressive surgery is indicated within 24 hours. There are several studies available which determined early decompression within 24 to 48, and 48 to 72 hours. And we've seen that early decompression within a 24-hour window is beneficial. And it also has been proven that it is safe and associated with improved neurologic outcome defined at least 2-grade AIS improvement at 6 months follow-up. And then now the surgical things are asked, and the surgeon is the main person after everything has cleared, the ICU, the stabilization, but we have to decide, is it stable or unstable? I mean, decompression is clear, but can we leave it as it is, or do we have to do further procedures? It's always a huge question, and therefore we have classifications. I mean, this is a useful and of course a helpful tool to determine stability or instability. Just to mention a few, we know we have many classification systems, at least for the cervical spine. We have the classification of the condyle fractures according to Hawkins. We have the Atlanto axial rotatory subluxation classification. We have the hangman fractures classification according to Effendi. Just like the 2 most common cervical classification systems, you have heard that it's like the Geweiler type classification. It's it has 5 types. The anterior arc, which is Guevara type 1. The posterior arc is Guevara type 2. Both are stable. Then you have the Jefferson fracture. It's a combination of both anterior and posterior, but it's not always unstable. This has to correlate with the transverse atlantal ligament. If you have a rupture or a bony avulsion of the transverse atlantal ligament, you see right down here, then it's unstable. Otherwise, this may be treated with a rigid collar. And then you have the Guevara type 4 fracture. It's like a lateral mass fracture on both sides, which also can be treated conservatively, depends on the dislocation. And of course, the Guevara type 5 fracture, which is located at the transverse processes on both sides. Then the classic odontoid fracture classification, Anderson and Alonso, with an oblique fracture through the odontoid tip, which is type 1, generally stable, soft collar, 6 to 8 weeks. Then you have the very common odontoid type 2 fracture through the base of the dent. This is the weakest spot, especially in the elderly, and we have seen in the past 2 decades an increase in elderly patients with an unstable odontoid type 2 fracture, and these are almost 75%. And the type 3 fracture, which is through the axis, and this is highly unstable in almost 1/3 or 25%, but this can, if there is no dislocation, be treated with a rigid collar. So, and because we have so many classifications and we don't have all these classifications available immediately, there are newer classifications who summarize all available classifications, especially for the cervical spine, where we have many classification systems. It's the AO spine upper cervical injury classification system, where they summarize the occipital condyle and the craniocervical junction, the C1 ring, the C1-2 joint, and the C2 and C2-3 joints. And what we can take into account is that type A is the bone injury. You see here on the first line, it's bony, stable. Then you have the type B, where band or ligamentous injury occurs. This is either stable or unstable. This is some kind of gray zone, we would call that. And of course, the translational injury, the type C, is unstable, but I guess without any classification system, every one of us will know that this is highly unstable and needs further surgical treatment. The same is true for the area below this C2, C3 area, also from the AO spine, summarized with all available classification systems so far, where you have type A, compression injury. It's actually similar to the thoracolumbar classification, but they have a separate one for the subaxial cervical spine. It's a compression injury, which is type A. You see this on the left side. It's either stable or unstable. I mean, we can say if the posterior wall is involved, this may be unstable and needs further surgical treatment. The type B is a distraction injury, where we all know it's unstable, and the type C, a translational injury. The same is true for that. It's unstable and needs further surgical treatment. And then we have the thoracolumbar injury classification. Well, I guess I would say we're all familiar with that. It's just type A is bony injury only, so therefore stable. And then when the tension band and the ligamentous injury also, especially of the posterior parts of the vertebral bodies are involved, it's either stable or unstable. And of course, type C, the translational injuries, whether you have a three-dimensional dislocation. As you've seen, we have some parts in the classification where it's not clear, is it stable or unstable? If you have a fracture at the thoracolumbar junction with involvement of the posterior wall, a so-called complete burst fracture, there is a helpful tool which has been published by Alexander Vaccaro in 2017, and this is actually for those cases where they validated this classification according to an international renowned committee, and they had a consensus, and they found out that patients with below 4 points do not need surgical treatment, and patients with 4 to 5 points need surgical treatment, and patients with over 5 points need surgical treatment. For example, if you have like an A4 fracture and a neurological status is they have neurologic injury and it's not 0, this means they have some kind of deficit. Of course, surgery is indicated, right? So you have to bring the neurology, but I think it's clear for us, yes. If a patient has a fracture, either stable or unstable, if they have neurology, this should be treated surgically, of course, decompressed and then stabilized when instability occurs. Yeah. But this is like a useful tool you can use if it's like a so-called gray zone, you don't know, yeah, stable or unstable. I mean, decompression may or may not be clear, but if you need like a guideline, if to do surgery or not, you can use this classification and take the neurology into account. So, and now what are the goals of surgery after acute SCI? Of course, stabilize the injured spine, decompress the spinal cord, preservation of neurological functions, and prevention of further damage. Especially patients, they may be stable, or like unstable, stable, not clear, do not have neurology. We have a bit time, but then if dislocation occurs, it will be unstable and the patient will have potentially neurological damage afterwards. And a case example, and this is the odontoid fractures. You see on the left side, a patient presents after a simple fall from slipping at home with neck pain afterwards. You see the scap here, it's the odontoid type 2 fracture. And you see there's no dislocation, and this was initially treated conservatively externally, and then came to us with further neck pain. And then we did a CT image and see that dislocation occurs. And of course, without any classification system and without calling the attending, it is clear that this is an unstable fracture. And this is a 88-year-old female, but still Asia E. Yeah, so we still do not have a deficit, but this patient needs surgical treatment. And of course, we, first of all, the intra-op reduction, we put on a Mayfield's clamp and then gently reduce the fracture under X-ray. If you have, for instance, a Gardner-Wells system, or you have a system where you can put kilogram by kilogram for the reduction, you can use this, but we can get also without monitoring a good result of the reduction by gently reducing the fracture using permanent X-ray imaging. And what we did is a posterior C1 C2 fusion. You see here we use the palm technique. We published on that in 2017, the posterior arc lateral mass screw. Especially for patients who are older age, this is safe because you don't need to dive into the epidural venous plexus. You don't get into conflict with the C2 nerve roots on both sides. And you, of course, have to see the vertebral artery, or at least know where it is. And you can do this very safe using spinal navigation and receive great results. Another patient, 76-year-old patient, who also had an accidental fall at home. He got an incomplete SCI with an Asia C status. And what we first of all see on the X-ray on the left side, it's degenerated C-spine with anterior osteophytes, and an additional performed MRI scan receives not only a listhesis here, but also high grade stenosis on both levels, and you also see signs of myelopathy. What we did with this patient was a 2-level ACDF, C4 to C6, using a cage with integrated screw to improve stabilization, because we've seen the listhesis and we do not want to insert a plate, because we all know that patients with older age receiving a plate will have dysphagia postoperatively, and you have to drill down the osteophytes, which will take longer OR time and could potentially cause more morbidity. And we did this patient within 24 hours as recommended, and at least he recovered from Asia C to Asia D upon discharge. This time, a young patient, not always the old ones, a 47-year-old male patient involved in a high-speed MVA with a T5 fracture. It's a T fracture. You can see it on the left side in this emergently performed CT scan. We have this vertebral body who has some kind of fracture line, and then the trauma went through all posterior elements at multi-levels. This patient had a complete spinal cord injury, an Asia A grade. And you see here the emergently done MRI with edema all the way in the muscles, in the ligamentous and band structures. And what you see here on the right lower image is some kind of transection of the myelin. Yeah, so we already see changes and something happened there. And after we did this also within 24 hours and performed emergency surgery. And what we found after multi-level laminectomies, like the dura mater was like opened in all directions, and the myelin was transected. So it was clear after we've seen those images that this patient will not recover after surgery. And what we did was a posterior fusion from T2 to T7 with multi-level laminectomies, you see on this side. And what you also see that we always go for the largest screw available, and often they are as large as the pedicles. The larger the screws, the more stable. It's not dependent on the length, what we know from literature, but the thickness is very important. And we always use CT navigation, and you cannot do this with this diameter and this trauma without navigation. This is my opinion. And what we said, no neurological recovery occurred. Another 86-year-old male patient. This is a patient who had a known history of neck pain and also slipped at home. And the cervical CT scan revealed an impression fracture of the end plates. And we see some kind of fragment going through the myelin, and the MRI revealed an edema. It's the myelopathy. And he had an incomplete SCI with an HRD grade. And what we did was an anterior fusion from C4 to C6 with a corpectomy on C5. And this patient recovered fully after 6 months. I just want to show that there are many ways to do surgery. It's not always the anterior, the posterior, or the combined anterior posterior. At least it has to be stable, and you can decide which is the right thing for the patient. And what I always would go for is like invasiveness. For instance, if you have very sick patients, try to do minimal invasive procedures. Yeah, this is some kind of pitfalls you have to take into account. And another example is a 32-year-old male patient who had a downhill bike crash. He was fully protected, but yeah, still the trauma was too high, and he revealed it to one fracture. It's a type C fracture. We have a dislocation, we have a translation, and we see that the force went all from anterior to posterior with a fracture of the spinous process, and he had an incomplete spinal cord injury with ASC. And we decided to do reduction to realign the spine with a C4 to T3 fusion. And what we also did, because it was a young patient, and we did a T1 corpectomy through a sternotomy from anterior. And you can see the results here in the lower part of the slide, where we insert an anterior plate right close to the screw. And you see here also the pedicles are so small, but we still go always for the biggest screw available. And this patient recovered fully after 3 months. So we achieved not only a radiographic great result, also a neurological, very, very acceptable results. And what we mentioned a couple of times before, and don't forget, we don't have only spinal cord injury at the cervical or half thoracic spine. We also have the mid to lower thoracic spine and the thoracolumbar junction. And what we know is that patients with ankylosing spondylitis have an increased rate of SCI because of the increased incidence of vertebral fractures. These factors, combined with a highly unstable spine, as we all know, and it is predisposed to a highly distracted injury, and we have spinal epidural hematomas in 60% of cases, the SCI may further increase in this population, the so-called delayed spinal cord injury. And this management of ankle spondy fractures in this also cohort is always challenging, because we do not only have a highly unstable spine, we also have very complicated and very morbid patients. So in this case, or in patients with ankle spondy, you always have to go for a large surgery to stabilize the spine, to avoid a pivot point. If you do not go too high or too low, this pivot point will break this spine again. And we often see this gap in between, and some surgeons prefer to insert a cage, but this is not necessary. We know from recent studies, we know from internationally known opinions that it's not necessary. The gap can be left as it is. Do surgery as good as possible, probably use MIS techniques, but leave this gap as it is. And the patients, it's not already published, but our department worked on that. We revealed a mortality rate of 30% in very elderly patients after 3 months. And finally, be always prepared. Be prepared for the worst case scenario. And I promise you, you will get this call in the middle of the night, not regularly where you have your specialists in house, in the middle of the night. An older lady, 83 years old, this happened here, had multiple spine surgeries, not here, somewhere else, anterior a couple times, and then posterior, and then came to us emergently with an emergency department. And this patient had T2 burst fracture, a so-called DJK, distal junction failure, with an acute SCI, incomplete SCI, with an HID status. And what I want to say, okay, it's in the middle of the night, we can do surgery, we can at least decompress, but don't do this in the middle of the night. You need an optimal setting, you need an optimal logistics, and we have 24 hours. There is no evidence to do this within 8 hours. You may or may not give cortisone in younger patients who may have something like that within 8 hours, but there's no necessity to do surgery in the middle of the night, because it's a highly, highly complex case. And you need not only to decompress, you need to realign the spine. And of course, this patient is 83 years old. You need an optimal anesthesiological management, sometimes many anesthesiologists in-house. And what has been done was a complex revision surgery with a transpedicular TT corpectomy. Like for T2, it's always difficult to do a classic costotransversectomy due to the scapula, but a small mesh cage through transpedicular is always a good possibility, and then extend this construct to T9. And this is nothing you will start at 3 a.m. in the morning. So in conclusion, what we do need is an optimal pre-hospital and hospital logistics. You need an ICU setting with respiratory, hemodynamic, and cardiac monitoring. You never know what happens. Some patient with an acute cervical SCI come, everything is okay. Within a couple of hours, you see a worsened situation. Early surgical decompression within 24 hours. Use a classification system in your daily clinical practice. You can print this out. Pocket cards are available. The more you use it, the more familiar you will get with that. Surgical therapy must be adapted individually. Do it posterior, do it MIS, do it anteriorly, do it combined. So this has to be adapted. And of course, a concerted interdisciplinary effort is favorable, as always in spine medicine. So thank you very much for your attention, and I'm happy to hear some questions.
Yeah, yes. Dr. Isak, many thanks for this surgical contribution. for the update of spinal cord injury treatment. There are a lot of questions already in the Q&A section. And if I may gather some of them. For example, Jan Lodin is asking, what do you think about multi-level laminectomy, durotomy, and myelotomy in cases of spinal cord injury with edema? So really aggressive decompression of the spinal cord. And another anonymous question, what is the indication for decompression by or in patients that cannot be directly investigated, who are comatose? So again, how radical should the decompression be? And a question by the chair of our trauma section, Niklas Marklund, from Lund in Sweden. What is the role for ultra early decompression? The question is it sufficiently fast within 24 hours, or should it be done as early as possible? So these are questions, how radical, how aggressive decompression should be done in the ultra early stage. And your case 3 is somehow corresponding and somehow answering the question already, but maybe a quick statement from you again.
Okay, thank you very much, you three, for these great questions. I hope I can remember those questions. For me, it's always difficult, but let's start with the first, not anonymous question, like myelotomy, durotomy. We know that, and we know people who've done that. We have not done this because there has been scientific work on that topic. Like the edema expand the dura to, like, we know this like from neurosurgery with hemicraniectomy, edema in infarction. But for the spinal cord injury, it has not been proven that this brings a benefit. We also do not know if this worsened, but a benefit cannot be performed. You can split the myelin, you can extend the dura using artificial stuff, but there is no benefit. The second question was, I guess, multi-level decompression with laminectomies. What we think about multi-level laminectomies? I think in this case, maybe we're not very aggressive with myelotomy and durotomy, but multi-level decompression is, in our opinion, very beneficial, because, for instance, if you have epidural hematomas, if you have probably edema, we don't know if this is like scientific proven, but from our opinion, multi-level laminectomies is beneficial, but we do not have evidence for that. The third question was, again, what was it? I lost the last question. It was, what was the third question again?
Indication for decompression in patients who are not to be monitored because they are comatose.
Yeah, the thing is, the pitfall in this is, like, the patient is comatose, you cannot assess this patient, but you always have some kind of imaging, either a CT or probably, if you're in a large hospital, MRI scan. If you see there is instability, if you see there is hematoma, if you see there is any kind of compression, please treat this patient surgically if possible. Of course, if he's cortically and respiratory stable, please address this case also surgically when this is okay for the patient, because once the patient is awake, probably in days or weeks, then all is gone. You know, you lose a lot of time, and especially the important time. So please treat this patient. And again, I remember the second part of this question, ultra early decompression within 8 hours. There are studies, and I know there is a study from Austria, I guess published within 1 or 2 years before, where they try to figure out, is there a difference between 8 and 24 hours? There is not a difference. So 24 hours is the goal, and higher is not good, and below 24 hours is not beneficial.
Yes, thank you, Dr. Isaac. There was another question exactly concerning this issue by Alice Hachel. Recently, there have been 2 meta-analyses on urgent decompression within 8 hours after SCI with neurological improvement, especially in complete. Any comments on that? Maybe just
yeah, I know this meta-analysis very well. I mean, let's say from a logistic point, if like this can be done within 8 hours, you can do it. But if we say we want to have evidence for that, we want to have proven mechanisms for that, it's not clear. This is the statement to that.
Then there are 2 more questions, very brief questions. Type 3 odontoid fracture mentioned as unstable, question marks?
Yes, of course, it's an unstable fracture, and
okay.
yeah,
okay.
it's clear.
Another question, steroids?
We know we can administer within 8 hours when we go for literature, but I personally, I would not, I would give young patients steroids, even if it's not within 8 hours, because I do not think, and I haven't seen or heard that young patients died from pneumonia or get a septic shock if you gave them steroids. And we do this commonly, and we haven't seen any adverse events here at our department.
And also a very short final question, because we have to move to the next speaker. Role of immobilization on treatment. It's not treatment, but let's say conservation of cervical injury where no facilities for surgery.
Of course, if you do not have the specialist, if you do not have the capacity, of course you have to immobilize the spine with a rigid collar. You don't have any other chances, but you have to take or bring this patient to a larger hospital who can treat that. But of course, surgery is indicated in unstable situations.
Okay, thank you very much, Dr. Isak. I think we have to move on for time constraints and move to the next speaker. Maybe you look also into the Q&A section and try to answer again in written words the answers you couldn't give. And now I would like to switch to the second speaker, who is Professor Weidner. I introduced him very briefly already in the beginning. He's a neurologist working in the Department of Orthopedic Surgery, Trauma Surgery, and Paraplegiology. That's his field. And he is very renowned, internationally known. He did his studies in Würzburg, did a postdoc fellowship in San Diego in the Department of Neurosciences, then moved on to Regensburg, also a German university city, well known, where he was as a consultant for neurology, and then finally got a chair here in Heidelberg in 2009, and he's focusing on paraplegiology. And I would like to welcome him and would like to thank him very much. And he would now give his thoughts and views on, of course, conservative treatment, rehabilitation, and conservative management of spinal cord injury. Professor Weidner, it's all yours now.
Yeah, thank you, Professor Unterberg, for this really kind introduction. Also, thanks, Professor Unterberg and Dr. Junzi, for the invitation and the opportunity to present to this international group of neurosurgeons. And yeah, I hope I can enrich your knowledge in a way. So I see myself as being second in line after patients have been admitted to your hospital and properly treated in the very acute phase. Then those patients are transferred to our facility. And yeah, this is where I'm gonna start my presentation, and hopefully you can see it.
Yes, everything's good.
Good, excellent. So let me just get this out of the way. Overall, my presentation will not be, has not the intention to give you a comprehensive overview about all routinely applied rehab interventions, including also research strategies. So I would like to focus on, let's say, innovative strategies in the field of rehabilitation, as well as in the field of neuroregeneration, and mainly also in fields and aspects we are also involved in, and it's not just supposed to show you that we can miraculously cure spinal cord injury. Unfortunately, this is not the case, but we are dealing with it, and we were trying to investigate interventions, and I would also like to expose you to let's say the challenges that we face when trying out new therapeutic interventions. And I guess what you see here on the left-hand side is something you're all too familiar with. It's just really just simplified in this cartoon. So you have a spinal cord injury, be it on the cervical or thoracic or lumbar level, with a cord compression in the end that severs all or some or more or all descending motor pathways, as well as ascending sensory pathways. On top of that, autonomic pathways that control the extremities, that control inner organs, and also exemplified one important organ that is out of control is, for example, the bladder, that can no longer be voluntarily voided, and thus measures have to be taken to circumvent the problem. And you've just heard from the previous speaker very nicely how an acute surgical intervention can look like in very specific fracture aspects, and how you fix it, how you decompress it. And of course, after that, intensive care usually is the next step to deal with all the immediate complications of spinal cord injury. So in our case, so we are a comprehensive spinal cord center. We provide comprehensive spinal cord spinal care, and we are a rather interdisciplinary and multidisciplinary team of conservative medical doctors, of trauma surgeons, so a really mixed bag, including very experienced nurses, very experienced physical therapists, occupational therapists, psychologists, and you name it, and social workers. So for us, the challenge is really to still cope with all the acute aspects of spinal cord injury, and at the same time, as early as possible, integrate those patients into rehab interventions, which is sometimes a really small path you walk on, and with the let's say optimal end result to get the patient out of the hospital as independent as you can. And of course, that depends always on the injury severity as well as on the level of injury. And as I said, one aspect, and it's, I guess, probably the most important aspect of all SCI patients, is to be equipped with as much independence as possible when they leave the hospital. And with rehabilitative interventions, we can do only so much. We cannot cure spinal cord injury, as you know, but of course, we have developed, let's say, compensatory strategies to find ways that patients can get independence back. Of course, not completely in all cases, but at least to some degree. And for this independence, of utmost importance is proper arm and hand function. And Christopher Reeve, whom at least the elder individuals in this audience may still know. So he's a famous American actor who fell from a horse and was lifelong, he remained on the ventilator and was not able to move his upper and lower extremities. And what he said was, obviously, my new life means adjusting to the fact that I can never be alone, means he is always 24 hours, 7 days a week. He is dependent on caregivers. And therefore it's only logical that if you ask especially chronic SEI patients, cervical SEI patients in particular, what would be their priority if we would be able to give it back, that it would always be, or in most instances, arm and hand function. And one good example you see here on the right side, so that's a patient with a C5 complete injury. So he has a biceps function, but basically no hand function, as you can see. So he's not able to transfer a cylinder or any other objects from A to B. And of course, that does not just refer to this abstract situation, that also refers to daily activities like grabbing a fork or a pot of coffee or things like that, and just steer it to his mouth to feed himself. And so question is, do we find ways how to compensate that and to overcome that? So typically, and this is simplified here in this animation, is so you have an intention to move your upper extremities, and the signal is sent down your spinal cord towards the peripheral nervous system, and in the end to the respective end muscle, and then this voluntary movement happens. And after spinal cord injury, obviously, this signal is no longer transmitted along the central cord. However, and that is, I would call it the engineer's perspective, the lower aspect, meaning the lower motor neuron from the spinal cord through the peripheral nervous system to the muscle is still intact. And what you can do is you can apply electrical impulses to stimulate those paretic muscles. And if you do it in a rather coordinated fashion with other muscles, then you can sort of restore a coordinated movement, which means also restoration, at least partial restoration of function. And how that happens, you see here. So there are different flavors this would come in. So as shown on the left side, this would be like the non-invasive variant. You apply a number of electrodes to extensor and flexor muscles in the arm that extend or flex the fingers and in particular the thumb. And if you then stimulate these muscles in a coordinated fashion, you can restore different kind of hand functions, allowing to grab, for example, a bottle or a fork, and as I said, steer it to the mouth. And that is all then happens through an electric stimulator who is able to coordinate that and needs an interface, of course, of a muscle or muscle system that's still intact to control this electrical stimulator, which then again controls the muscles in a coordinated fashion. So this system is, of course, it's rather easy to apply. It does not require surgery, but it's not very selective, can be painful, since this electrical stimulus in not sensory complete patients can be painful, and handling in times can be difficult. So of course, in the ideal world, it would be nice to integrate that into the body. So implant the electrodes directly on the muscle. The rest pretty much remains the same as you see on this right side cartoon. And in this case, for example, if the shoulder muscles are still intact and can be voluntarily moved, you can integrate a joystick there. And with this shoulder movement, you control the joystick, which then again controls the electrical stimulator, which controls the respective muscles, and you can induce proper hand function. Of course, this advantage is it has a better long-term stability. It's easy to use, but it's invasive, and it's I guess only suited for chronic SEI patients. And how it really works, you can see in this concrete example. So this is a patient that you saw before, and after implantation of this electrodes and the stimulator, you can see that the patient is able to grasp objects, to move them from A to B, and he controls opening and closure of the hand with the movement of his left shoulder. So if you look closely to the left shoulder, you see this movement that he performs when he switches from closing to opening of the hand. And that does not only work in these abstract situations, it really works in real life situations. And this patient worked with this system for almost 10 years. However, then he got an infection of this electrodes along his muscles, and the company unfortunately went bankrupt. There's no new company who produces this kind of electrodes or this kind of system, and therefore it had to be explanted without reimplantation, which was actually pretty sad because that really raised the level of independence in this patient. Of course, there are other means if, for example, shoulder function is no longer present, to sort of steer such a system. And one system would be facilitated through a brain-computer interface. You may have, I'm sure you have heard of brain-computer interfaces. Basically, what is done, you find specific patterns, for example, a movement intention, and that can be detected with specific algorithms, and can then be fed into an effector system, as you have seen, which would allow you to also control at least a part of the movements of arm and hand. And that this works in principle, I can show you in the next slide. What you also need to be aware of, this is a non-invasive system. So all we work with here in Heidelberg are non-invasive systems. Of course, there are invasive systems which have advantages and disadvantages, just like also the electrodes on muscles. But our system we are working with is a non-invasive system that patients can put on if they need it, or leave off if they don't need it. Of course, handling is an issue that needs to be solved. And let me just get rid of the tone here. So what you see here is a patient, as opposed to the patient you saw before, he has no elbow flexion function left, and therefore he would not be able to put an object towards his mouth if he would not have an additional support. And this additional support is applied in the way of a motor orthosis that allows technically facilitated elbow flexion, but on top of that, he also needs to be equipped with hand flexion and hand extension. And this hand extension and hand flexion is made possible through this electrodes placed on respective muscles. And as you have seen in the patient before, however, the patient needs to be able then to switch somehow to this motor-driven orthosis to flex his elbow. And this switch from one kind of movement of the hand flexion extension to the elbow, that is then, let's say, made possible through this brain-computer interface, which through movement intention allows the patient to switch to his motor orthosis and allow elbow flexion. And this is what you then see in the lower right video. So here he switched to this motor-driven orthosis, and only that allows him in the end to lead this ice cube or this ice cone towards his mouth. So in principles, you see that things like that work. However, they require a lot of setup, which of course in daily life is not something that is really feasible as of now. But as you know, technology develops further, and maybe in a couple of years there could be a system that at least could work in very severely affected cervical spinal cord injured patients. So another aspect that relates to rehabilitation is, of course, how do we deal with patients with incomplete spinal cord injury? So those are patients that have remaining motor function, and there we might have the chance to restore function. And as you see, so these are some data from a database in Hamburg that collects data from all SCI patients. As you see over time, from 2005 to 2015, the number of incomplete SCI patients increases, and therefore this is a relevant aspect of spinal cord rehabilitation. And one treatment modality you may know is for example, body weight supported treadmill training, as shown here. This is a machine. Of course, this is one machine. There are other machines that you can use. They're equipped also with exoskeletons to support the paretic muscles. But this is a machine, rather big machine, that can only be usually started or run in a rehab facility. This is not something that can be used at home by the patient. But considering that the time for the patient in a hospital or in a rehab facility gets shorter and shorter, Rüdiger Rupp, here in the clinic, electric engineer, developed a system that sort of mimics this body weight supported treadmill, but allows the patient to use that kind of device completely by himself without any caregiver assistance to transfer into this device. He called it Morgate, and it really tries to mimic many aspects of body weight supported treadmill training. As you can see here in this video on the right side, it even has a some kind of sensory stimulation on the foot sole that also mimics the movement while you walk about a surface, which are known to be important stimuli for walking movement. And he did a pilot study for that in chronic SCI patients. And as you see, so this is a 10-meter walk test down here. And as you can see, those patients, chronic SCI patients, so they should have already a stable condition of their spinal cord injury. They definitely improved in their walking performance, and 9 out of 25 participants required fewer walking aids. And as you can see here, they definitely improved in terms of their walking function. Of course, that needs to be maintained over time. This is not a one-time treatment, so this needs to be continued in order to really maintain the functional status. Yeah, so this was a brief excursion into rehab interventions that we are interested in dealing with. I think another dimension is to translate preclinical aspects of regenerative treatments into the clinic. And this is what I would like to tell you in the second part of my presentation. As you've seen in the previous slide, it is really a very, very long journey. And of course, that also relates to the fact that spinal cord injury is a rare disease, so we do not have that many patients. And as you know, for a clinical trial, you need as many patients as possible in order to tease out a treatment effect. And one study we are, let's say, key partner in the clinical trial. However, we have not developed a preclinical strategy. So this is work primarily from Martin Schwab from Zurich. I'm sure you've heard of it. So he developed a so-called anti-no-go antibody treatment for spinal cord injury. The way it works is that he developed an antibody that is able to neutralize certain proteins. They are called no-go, so the axon is not able to go anywhere after spinal cord injury because this myelin-based inhibitors get expressed, and if you apply an antibody, those proteins are neutralized, and at least to some degree, severed axons are able to regrow for a certain distance. However, prerequisite is that this will work only, and this is known from preclinical studies, in incomplete spinal cord injury. So, and this is just one out of many preclinical studies from Martin Schwab's group. So this is work in monkeys where they severed the corticospinal tract. That you see here shown in this camera lucida drawing in the left panel in black is transected, and you see below the injury very few spared fibers. However, if you apply the anti-no-go antibody, there are many more fibers that go beyond the injury site, suggesting that they are the neuroanatomical substrate that can help to recover at least partial function. And that has actually been shown in these monkey studies, but also in rat and mice studies as well. And we did the first phase 1 study, also multi-center study from 2006 to 2010, where we first in man applied this antibody. It has to be applied intrathecally, and it has to be applied several times. And those are really just a few glimpses out of this work. We can show that we have proper concentrations in the CSF as well as in the serum. We know that the administration route is safe, and we didn't observe any adverse events or severe adverse events that kept us from continuing with a phase 2 study. And unfortunately, the phase 1 was sponsored through Novartis, and they no longer were interested in this kind of therapies, and therefore we had to find a different, let's say, source of funding or way to conduct a phase 2 clinical trial, and we applied for a grant at the EU and got funding to run a multi-center phase 2 study, a randomized double-blind placebo-controlled trial where we want to learn more about the efficacy of this treatment with this anti-NOGO-A antibody versus placebo, and by repeated intrathecal injection in originally planned 132 cervical SEI patients with a completeness of A all the way up to incompleteness of AIS-C. And our primary endpoint in this trial is to look for the recovery of neurological function, in particular the upper extremity motor score. And of course, we are also interested in other aspects, not just the upper extremity, but also lower extremity sensory and motor function, as well as functional aspects of grasping, of walking, and autonomic function. Of course, we also look for adverse events, vital signs, pain, and spasticity. So this is how the intervention looks like. Patients have to be included within the first 28 days after injury. They receive repeated injection of the anti-NOGO antibody 6 times with an interval of 5 days in between, and then the patients are followed up for a total of half a year, and an additional half year they are followed up outside of the clinical trial within our international EMSCI network. And these are just trying some examples that try to highlight some of the, let's say, hurdles we had to, or that we faced. So number one, this antibody formulation was not ready when the project funding started in 2016, and so it took us 2 years to really get the antibody ready to be applied. And of course, this time was lost to include patients, and we started off with 7 centers Europe-wide in Germany, Switzerland, and Italy, Czech Republic, and Barcelona. And then we had to come up with mitigation strategies. So we added other centers in Switzerland and in Germany, which you see in the lower panel, to sort of raise our enrollment efficiency, and we were able to, luckily in the end, start this clinical trial in 2019, mainly with Swiss and German sites. However, as part of the EU trial, we of course had to activate the sites in Italy and Spain and the Czech Republic, but I'm not going to dive into the regulatory aspects related to such an international study, but to say the least, it's challenging to run a study in countries that are not speaking one language and have not one system in terms of regulatories. And one point I would like to also highlight is that all of this work was only possible because we had a preset international EU-wide network, so-called EMSCI, where we were already experienced and skilled to do all the assessments necessary since 2001. So we were pretty much ready to go to run this clinical trial. I think without that, it would not have been possible. And this is just to show you a number of assessments. You don't need to learn them or to understand them in detail within this EMSCI network, and also within the clinical trial. We do a number of neurological as well as functional as well as electrophysiological assessments in a standardized fashion at defined time points. And we collect many data, now more than 5,000 data sets across Europe from these patients to monitor and describe their natural recovery. So you see the number of core sets. This is up to 2018. So now we have, as I said, more than 5,000. Why do I mention that? This plays a role now because we had to adapt also the clinical trial design. We looked into these data back from 2001 until now, and we found those data, except for a few aspects, for example, like age of average age of SEI patients, that changed over the years, but the neurological and then also the functional recovery in these patients remained extremely stable over these years. I mentioned that because then we had the idea to also include more controls, well, you could call it historical controls, in order to save real controls, which would allow us to reduce the number of patients to enroll in the end, to be enrolled in the end, and of course that saves us time to still successfully finish the study in time, and this is what we came up with after intense discussions with our statisticians. We came down with a number originally estimated of 134 to 104, and we will have now a reduced number of controls that receive placebo, and we add external controls, meaning matched patients from the EMSCI database, in order to really have a proper control group. And on the right side, so this is a recent standing of our clinical trial. So we have now randomized and started dosing in 60 patients. Dosing completed is in 53 patients, and the study is finished by 38 patients, and we are quite confident that we're gonna be able to complete this clinical trial by the end of next year. And unfortunately, due to that fact, I do not have any results I can present to you in terms of efficacy. What I can tell you is that in terms of safety, we have all the adverse and severe adverse events are within the range that we would expect related to spinal cord injury, but not to the administration route and not to the drug. And that was also recently confirmed by the safety board that of course supports us and helps us to judge about all these aspects. Yeah, and at this point I'm at the end, so hopefully maybe at the next meeting, if I have the chance to present to you, I can show you first results, but I think that is just about to show you things are moving forward, but of course not as fast as everybody would expect. And I thank you for your attention, and if you have questions, I'm more than happy to answer them. Thank you.
Thank you so much, Professor Weidner. This was really an excellent overview. First of all, on the actual statement for rehab, and this was really fascinating, and also the no-go trial and the register trial, very important issues. My burning question after your talk: is there a role for neurosurgery, for example, in implantation of neuroprosthetics after spinal cord injury? Or will that be a role for whoever?
I would think so. I think this is a field that is still pretty new, and for example, I mean, I explained to you, addressed only aspects that are well under development and not yet established. So, for example, one aspect that's almost established as a clinical care treatment is nerve transfer surgery or muscle tendon transfers in order to improve upper extremity function. And I would think, since neurosurgeons are experts in peripheral nerve surgery as well, that is definitely an aspect that where contribution by neurosurgeons could be extremely helpful, as well as interventions that relate to electrode implantation, but that of course depends on whether such a system really would be available in a commercial fashion to use, which is not yet there. And just referring to neuroprosthetics in the upper extremities, but of course, I guess we will hear from Dr. Junzi about spinal cord stimulation, that there will be other areas of interest for neurosurgeons, where that would be extremely important to have this, of course, support.
Okay, yeah, thank you. There are questions in the Q&A section concerning stem cells, and we will postpone them because I know that Dr. Junzi will talk about this. But to Professor Weidner, do you have any experience in transposition of the C5, C6 nerves? Can you comment on this? Is this maybe surgically a valid option?
So you mean transposition at the nerve root level, or
yeah, or
exactly. Then on the peripheral nerve level?
Peripheral nerve level.
Yeah, no, we do not have experience yet, but we would like to really dig into that field, because there is a recent study that came out from an Australian group. I mean, that has been done over quite a few years now, but they did a really good job in doing it in a real standardized way, and that they presented extremely good data. And therefore, if we would have good clinical partners from neurosurgery, for example, to help us in accomplishing this kind of intervention, that would be extremely welcome.
Mm-hmm. Okay. There are some more questions, but unfortunately, I have to move on. Yeah. Because otherwise we will be have a close down.
Thank you.
A lockdown. And Dr. Junzi shall also have an opportunity to present his ideas about the so far experimental treatment modalities, opportunities of spinal cord injury. And of course, he will talk also about stem cells. Again, Norbert, many thanks for your contribution, and we will stay in contact.
My pleasure.
Finally, last speaker, last presenter will be Dr. Alexander Junzi. He's also a very young neurosurgeon in our department here in Heidelberg, and both clinically and experimentally, he's focusing on severe brain trauma and spinal cord injury. And now his presentation will be about potential, well, let's say future developments, how to attack spinal cord injury in terms of regeneration and, well, recovery. And the stage is for you now.
Thank you, Professor Leberg, for the kind introduction. I also will start my presentation now. I hope it should be online.
Yes.
Yeah, perfect. So I will directly jump to the pathophysiology of spinal cord injury, because I think we've heard a lot on epidemiology and also the surgical and medical treatment. But what is causing those severe deficits, and what is making this disease so complex and disastrous? Although we've heard that not so many patients are suffering from it. So we've seen images like this, very devastating injury to the spinal cord, and this is a primary injury happening in accidents and so forth. And it's not an injury that we can prevent, but the problem is that with this primary injury, a let's say secondary injury is initiated, and this is mainly due to compression of the spinal cord, due to edema in the spinal cord, confusion in the spinal cord, and also ischemia. And as Dr. Ishak mentioned, and he's shown a lot of really nice cases, mechanical instability is adding to those effects. And the secondary injury is what we try to treat as neurosurgeons, as neurologists, and our treatments basically mainly focus on the neuroprotection. So ICU treatment, we elevate the blood pressure, we perform surgical decompression, as we have learned, and we can, in some cases, offer corticosteroids. But the problem is that this secondary injury is just the tip of the iceberg, and it's ongoing until chronic stages. It's basically ongoing until weeks and months after the primary injury, and it leads to a lot of very distinct processes in the injured spinal cord. and some of them are shown here. So we see astrogliosis in scar formation. So the extracellular matrix is forming a scar, the astrocytes form a scar. We see a cystic cavity forming in the spinal cord. We see ongoing inflammation and edema. And of course, from the first second until weeks after, we see separation of axons, we see demyelination of axons. So this injury actually goes on, and it makes it so difficult to treat. It's really heterogeneous, and it makes this event so disastrous. And patients have lifelong deficits. There's no cure, as Professor Weidner said, loss of independence. And we didn't talk about this yet. We won't, but the socioeconomic costs, although it's not so many patients, are very high. And when patients are asked what they want to improve for themselves, Professor Weidner also showed this in his presentation. Basically, they are asking for neurodegeneration. So they want to have restoration of motor, bowel, bladder, and sexual function. And paraplegic patients, of course, want to regain mobility. And then tetraplegic patients, they are really happy if only they could use arm and hand function, because that would make them less independent. And regeneration is a big problem. And well, what does it mean? It means replacement and repair of the neural structures that are making all these functions possible. And those are typically neurons, glial cells, axons, synapses, myelin sheaths, and all the other cells and structures in the spinal cord. And the problem is that this neuroregeneration already under normal conditions in a healthy spinal cord are really limited. There is, nobody knows why, but there's limited cellular plasticity and also presence of growth inhibitors. Nogo was mentioned already. And when you now add the injury, there are severe physical and chemical barriers that make neurodegeneration basically nearly impossible. There's this astrocytic scar. There are fibroblasts that are replacing the extracellular matrix with fibrous connective tissue. So the environment is really bad for regeneration. And what this means is that the only way for patients to regain some function is to support and to improve the neurodegeneration that is not happening on itself. And the only way so far is, and we've learned about this now in depth in the last presentation of Professor Weidner, is rehabilitation. And we know, and we do this, that we should start with it as soon as possible. And there are several really nice and sophisticated ways of doing this. But as Professor Weidner said, it's no cure, and the effects are still very limited. And luckily, there has been and is still a lot of research going on this field. And it's really astonishing to me because, again, it's a fairly small group of patients, but there's a lot of research and there are a lot of preclinical experiments and studies, and people are really interested in treating this disease. This is just a PubMed hit for spinal cord injury neuroregeneration, and you can also see that interest is really rising. And in my talk, because there is so much to talk about, but I want to focus on a couple of fields that I think are interesting and also that have been, in parts at least, translated into clinical studies. And some of those fields are really emerging and are, I would say really interesting, but I hope you will agree at the end. So first of all, I want to talk about drugs. And Professor Weidner already presented the NISCI trial, and I think this is an astonishing trial, and everybody's looking forward to seeing these results. I will skip this, but there's another drug I want to introduce, one that has been talked about a lot in the recent years. It is based on the problem of the Rho-ROCK pathway in the injured spinal cord. So this pathway has been associated with impaired regeneration. It increases apoptosis of neurons of glial cells, and it leads to activation of proteoglycans in the extracellular matrix. So it's a bad pathway, basically. I mean, it's a little broad, but I think you can sum it up like this. And luckily, there is a way of antagonizing this pathway, and there's an antagonist for the Rho protein, citrine, and there have been a lot of promising preclinical findings on this drug, and there have been animal models that have shown that long-distance regeneration of neurons is possible, functional recovery is possible. So this drug has already been translated into the clinical practice, but clinical trials, and there's been a phase 1 and 2 trial with 48 patients. It has been published in 2011, so this is quite old. And it just showed that Cetrine was very well tolerated, but also that a third of the patients showed improvement, which was pretty astonishing, from ASIA-A, so complete injury, to ASIA-C to D. And those positive results, as usual, have been used, and phase 2b/3 trial has been performed. This is just the publication in 2018 that provided information on the study design. And the way this has been administered was during surgery in 70 patients with acute cervical SCI and also a very severe injury, ASIA grade A and B. During surgery, we learned about surgery. So those patients received surgery. The drug was mixed with fibrin sealant and it was added on the dura mater. It's really interesting. So it had to diffuse through the dura. And this study assessed the upper extremity motor score after 6 months. So the focus, as usual, cervical spinal cord injury is function of the upper extremity. And this study has been terminated in 2018. And so far, this is quite sad, no results have been scientifically published. But if you look at the clinicaltrials.gov website, they have been forced to publish results there, obviously. And if you look at it, you see that there is obviously no significant effect of the drug in this trial. So probably there will be, I don't know if there will be any publication, but it seems like the trial has failed and we're still waiting for some results. But this would be maybe a sad end of this pathway in this drug. But there are other drug trials on the way. We have also heard from Professor Weidner that it's really difficult to perform phase 3 or clinical trials in spinal cord injury because not so many patients. But interestingly, in Taiwan and also skip to this directly in Japan, there are still 2 drug trials. I mean, overall, there's maybe a handful. One is using recombinant human acidic fibroblast growth factor, and the other one is using hepatocyte growth factor. So 2 growth factor studies used as drugs by pharma companies. And one aims to, it's an RCT, a multicenter randomized double-blind placebo-controlled study. So a nice study protocol, and it aims to include 160 patients. So a huge effort. And it just started in 2017. And maybe there will be some results soon, we don't know. The other study has only 25 patients and it just started. So we'll see. And there, I think, is some hope for those 2 growth factors to show some effects. Now let's switch to stem cells. Stem cells have already been discussed in the group chat here, and they are kind of omnipresent and also not only in spinal cord injury, in many diseases, but also in spinal cord injury. And we have been following stem cells. The research efforts that have been made have been going on for, I would say, 2 or 3 decades already. So they are supposed to provide trophic factors. They are supposed to modulate the inflammatory response, regenerate lost neural circuits, and also remediate denuded axons. And then some of them are also supposed to integrate into the spinal cord and really differentiate into cells and replenish cells. There's a lot of different stem cell types used for transplantation after spinal cord injury. And I will try to focus on the mesenchymal stem cells, the neural stem cells, because I think that researchers have most experience with those cells, and they have been used for the longest time. And the others are, I would say, rather emerging. But let's start with the mesenchymal stem cells. So mesenchymal stem cells have been used for transplantation strategies for over a decade. The results have been published in 2012 already, and the group by Cretin-Mon et al. Have shown nicely that the mesenchymal stem cells after transplantation in animal models of spinal cord injury lead to more angiogenesis and also improved motor function. And there have been a lot of similar preclinical findings and studies, a lot of really promising results, and mesenchymal stem cells have already been translated into the clinical practice. There was a phase 3 trial already published in 2016 in Korea as well. And this study included 16 patients, so it's a rather small study. And the cells were transplanted in the chronic phase after spinal cord injury, so already 12 months after the trauma. And unfortunately, only 2 out of these 16 patients showed any improvement. So this study, I mean, they nicely showed that the transplantation in humans is possible, no side effects, I mean, in the short term, but no real benefit as well. So it's rather a negative trial. That's why newer studies and also our lab in Heidelberg has focused on NPCs, neural precursor cells, because in contrast to mesenchymal stem cells, they have at least the capability of differentiating into neurons, glial cells after transplantation. They really are supposed to also replenish the cells that have been lost. And we have worked with those cells for a couple of years, and we've, for example, shown that they also, when they are transplanted, for example, in the subacute phase after injury in animal models, attenuate, so improve the inflammatory reaction. So they have other positive effects on secondary injury processes as well, shown here with macrophages, and they also reduce apoptosis. And there have been a lot of similar studies, and I want to point out one really impressive study by Lu et al. Published in Cell in 2012 already. So this has been really well recognized, because the authors have shown that when they transplanted neural precursor cells in a transection model, where the spinal cord is really cut, they can still observe outgrowth of axons of these NPCs, of these stem cells over the lesion, and they have also shown nice integration of the cells, and they have also shown really nice functional recovery of these injured rats. And positive findings like this study have led to a couple of clinical trials on the transplantation of neural stem cells. One has been published in the Journal of Neurotrauma in 2018. This has been a multi-center study, phase 2, proof of concept in 12 patients. And the study has been terminated, unfortunately, because although no negative effects have been found, no positive effects have been found as well. So this is one of the NPC studies that is also, I would say, a failure, or no positive effects. And this is a little bit a problem of stem cells. There have been a couple of nice reviews recently. This one has been published last year, and the authors have tried to summarize all the completed stem cell trials in spinal cord injury treatment so far. 18 such trials have been identified, and 14 of them with the older MSCs, and 4 with them with I would say newer NPCs. Some of the studies are really impressive. Phase 3, some of them are 300 patients, but the problem is that first of all, those studies are really heterogeneous. The methods, the outcome measurements, everything is different, and it's really difficult to compare the results. And the other problem is that a lot of those trials have never been published. So this is a little shady, and it makes you think what is happening there. And for the ones that have been published, at least no severe side effects and mostly promising results, but nothing that really has been really astonishing. And currently there are 12 more clinical trials, even phase 3 trials ongoing. And I mean, some good results might be expected, but a problem of stem cells is that they are fairly complex to administer, to prepare. The logistics are complex. They typically require immunosuppression. And even in the preclinical studies, the survival of those cells in the injured spinal cord, especially in the acute phase, is really low. So personally, I see a lot of problems with this with this treatment per se. But you never know. We'll hopefully see better results in the future. Meanwhile, stem cells and stem cell therapy can also be used differently. We have looked at the secretome, and others have looked at the secretome, so extracellular vesicles that are secreted by stem cells in depth. And this has mostly been done with mesenchymal stem cells. And those extracellular vesicles, exosomes, for example, they are a hot topic anyway, because they have become the focus of clinical applications as biomarkers, also as treatment options in other diseases. And also in spinal cord injury, there have been reports, mostly on mesenchymal stem cells, that when you use their exosomes, you can isolate them, and you can also quantify them, and you can characterize them, and you can look at their cargo, and they have really impressive cargo. So they have growth factors inside, and they have microRNAs and such. So authors have used those exosomes, and they have used them as an alternative to cell-based treatment, and have just administered the exosomes systemically in an animal model of spinal cord injury. And by this, they have shown that a lot of secondary injury processes are improved, for example, in neuroinflammation, and also functional recovery is improved. And the theory is that what stem cells do, the positive effects they bring, they also use their exosomes. And if you just use the exosomes, you still have a couple of the positive benefits from stem cells, but you don't have all the downside effects and all the negative effects and all the problems. And we have started to look at the exosome of NPCs, of neural precursor cells. We think NPCs are the better alternative in general for stem cell therapy. This is a paper published recently where for the first time such exosomes from NPC have been characterized, and authors found that they contain a lot of or a specific microRNA, and they promote neurogenesis. And we have now successfully isolated exosomes from NPCs, and we have extensively characterized those exosomes, and we have learned a lot about their cargo, and they also contain a lot of growth factors and signaling peptides. And right now we're trying to use those exosomes and treat cells in vitro, and also treat animals in an animal model of spinal cord injury. So there might be a chance of stem cells 2.0 to have a brighter future. Another way of improving stem cell therapy, and this leads me to the field of genetic therapy, is to modify or to induce the stem cells to more functional cells. So this group, Lee et al., this is really recent research, has used newer technologies to create stem cells out of fibroblasts, and then to induce those stem cells further into functional motor neurons. And then they have transplanted the motor neurons, not the stem cells. And they have really impressively improved the motor function in spinal cord injury mice, or in this case, rats. And the whole background here is that with newer technologies, and I want to introduce the field of gene therapy with two publications that have been really shaken I think the research world in the last year. The newer technologies like the CRISPR-Cas method have allowed researchers to genetically modify somatic cells by using, for example, viral vectors. In this group from Sioux, they have used an adenovirus, custom designed, and the adenovirus led to selective knockdown of a gene, of an RNA binding protein, PTPP1. And by this knockdown in selective cells, in glial cells in the eye, the glial cells have been converted to functional neurons. And in a glaucoma model of animals, of mice, the authors showed that mice can see again, which is really impressive. And the same technology, similar technology, and the same target gene, PTPP1, has been used by another group, and this has been published in Nature. And they have used a different adenovirus as a vector to introduce the genetic information into specific cells. They have targeted astrocytes in a Parkinson model, also in animals, so animals that had Parkinson, and they converted astrocytes to functioning neurons as well. And then they basically, I don't know, cured or improved this neurological disorder. And those were really impressive results, and researchers have begun to think about cellular reprogramming as a new treatment paradigm for various diseases. And also in spinal cord injury, this is a evolving concept, because silencing or expression of genes of interest via custom designed viral vectors in astrocytes and other glial cells is possible. It's doable, and it's not that complicated. And the new possibilities are in spinal cord injury, and we are actually working on this right now. We are creating viruses, adenoviruses and lentiviruses, custom made that only infect astrocytes. And we hope that we can convert astrocytes in vivo in situ to either neurons or even neuronal precursor cells, and to thus treat the glial skull and also boost available stem cells. So this is an evolving field. There's no clinical data on this yet, but gene therapy should be kept in mind, maybe can be translated to humans as well. Now, last but not least, biomaterials. This has been an important topic as well. And there have been a lot of natural materials and also synthetic materials that have been used to basically create scaffolds in the injured spinal cord. So this is an example for a plant-based nanotube material that has been used. This is an example for a 3D printed silicon based scaffold, and those scaffolds are typically injected or transplanted into the injured spinal cord in chronic injury stages, because then there is often a cystic cavity or a scar, and they are supposed to bridge the damaged tissue, and they are supposed to promote endogenous external regrowth and to improve the environment so that tissue growth in general and vascularization is facilitated. And also, and this brings me to the really important topic of combination, they are the perfect base for example, drug delivery or for gene delivery and so forth. So they can be equipped or loaded with even with stem cells, with drugs, and they then continuously pour out these substances into the spinal cord. And they are part of a lot of synergistic treatment strategies. And I think what I wanted to show you, and what I hope you have seen now, is that there are several individual treatment strategies in the experimental setting, and they all have, most of them have nice preclinical findings. Some of them have been translated into clinical studies, but with complex or not so convincing results. And a problem is that this disease, as I mentioned in the introduction, is really heterogeneous. There are so many different processes, and researchers and us as well in our lab, we have understood that we should focus on combining different individual approaches and find something that is synergistic in the way it works. And this has been done, for example, by Professor Zegberger, the leader of our lab. He has combined self-assembling peptides. So this is another biomaterial. It's liquid. You can inject it into the spinal cord. He has used this clip contusion compression spinal cord injury in rats and injected these peptides, and he has added neuronal stem cell transplantation. And in combination, he has shown that the stem cells survive nicely and that a lot of secondary injury changes are improved. We have in our lab also improved stem cell transplantation by additionally administering growth factors. And we have also, in addition, added treadmill training, which was really interesting. So by combining these three individual treatments, we have drastically improved survival and differentiation of the stem cells, but also the functional recovery of the injured rats. And another thing that has been done, we have worked with this master regulator growth factor sonic hedgehog as well. We have combined sonic hedgehog with stem cells. This is really recent data. And if you combine such treatments, in this case as well, you can improve functional recovery in combination, and you can also improve the individual treatment. So stem cells, they drastically improve their survival and differentiation if they are combined with, for example, sonic hedgehog or treadmill training or other individual treatments. And now think about combining, adding drugs to this, or adding gene therapy to this. So if you have a basket of treatments, maybe even customized to the patient, there might be a chance, and this brings me to the last slide, that this disastrous disease or event can actually be better treated or cured. So it's complex. It has a lot of different injury processes, not so simple. Endogenous regeneration is basically non-existent. Rehabilitation, that's the only thing we can currently do. Experimental treatments are heavily started, luckily, but there is no golden bullet yet, no single a treatment that has cured and made people walk. And I personally think, and so do other researchers, that the way of treating this disease, or maybe even to cure this disease, is to first of all combine different promising therapeutic approaches, and also when we translate our findings into clinical trials, to standardize trial designs, to modify trial designs, to maybe identify subpopulations of spinal cord injury patients that benefit more. And I think now that a couple of those trials are done by pharmaceutical companies, there will be some change in the design of those trials as well. So this is the end of my talk. Thank you, and I'm looking forward to your questions, obviously. Thank you for your time.
Thank you very much, Dr. Junzi. You really reviewed the huge topic very efficiently, and there are numerous ways how to get to a better regeneration. And well, if I may start with a comment of mine, you really nicely showed us that a lot of studies are going on. And to answer some of the questions in the Q&A section, a mere stem cell injection in spinal cord injury patients is of no good use. It's a no-go and should not be done. And it is like scarlatonism. Some people, and there are also some neurosurgeons who are injecting stem cells in order to foster and to improve regeneration, but it's of no use, number one. And number two, all these studies are experimental so far. Now, my question to you, you said there is no golden bullet, but one or two really approaches guiding into the future. If you would have to spend money, where would you like to spend it to get some regain, some repay?
It would require a lot of money. But I really think that this field of genetic, I mean, it's probably not the right terminology, but let's call it genetic therapy, is really promising, because why not use what is already there and just change the phenotype of cells and reprogram them so that they do no harm but do something beneficial. And this can be, right, with the technologies we have, this can be turned on and off. This can be custom tailored to specific cell populations. So the safety should hopefully be not the biggest issue anymore in the future. And this can be performed hopefully fairly easily compared to stem cell transplantation and such. So, and then the other thing is, as I said, I really also think that similar to traumatic brain injury, combination is key. So I put my money on genetic therapy, plus it's not part of the question, plus still combining other stuff with it. So that would be my answer.
Thank you. There are two questions from the section. What about the Yale study with autologous stem cells? And another one, you are probably aware of the INSPIRE study, in which US neurosurgical centers used PLGA graft in acute spinal cord injury to bridge the lesion. Comments?
Okay, so the first question, so I do not know the Yale study, but the idea behind it is I think I'm familiar with. So this is even more complicated to obtain, to perform. But of course, if you have an injured patient and you have you perform surgery and you obtain some tissue, even in the spinal cord, there's still an endogenous stem cell population. If you can isolate such stem cells, and if you can repopulate them, and you can use those stem cells for transplantation, I think it's even more complex, and I think it's not really realistic to translate this into the clinical practice for a lot of centers. But if you can, then you do not require immunosuppression maybe, and you might have better results. But I think for stem cells, the key would be to produce the stem cells in the lab in mass production, maybe even to use them to more specific cell populations and then transplant those. So I'm not so convinced of the autologous stem cell use. I hope that answers the question, but I'm not. I do not know the details of this study. Maybe they have really nice results.
Okay. Then how about the INSPIRE study in the US?
So
about
yes, so the graft again. So grafting the lesion site. So if you think about, so I do not know this study in detail. But the way grafts are typically used are in a chronic phase, chronic stage, where the lesion, there is already a lesion and there's a cystic cavity and there's a scar, and then you need something to bridge this. And in the acute stage, it's really difficult for me to understand what the scaffold of the graft, what it should do. But maybe there's some new synthetic material that can nicely integrate and even can be used as a scaffold in the long term. But the way this typically has been used is in the more chronic phase. So no clear answer here, but so in the acute stage, uncommon to use grafts.
Okay, Dr. Junzi, thank you very much. I think most of the questions within the Q&A section have been answered. Not all of them. Some surgical questions have been answered in between, I have seen, but there have been many more neurosurgical questions, no wonder, and this is a good sign. There are still 130 participants listening and watching, and this is also, I think, a great success, and I would like to thank in the end again the presenters, Professor Weidner, Dr. Isak, Dr. Junzi, for their presentations. I would like to thank the participants for joining us for a lively, well, it's still an online discussion, but nevertheless, I think there were many interesting questions, and maybe and hopefully many of you have learned and realized a lot. Well, if not already done, join the EANS and have a nice evening. Hope to see or to listen to you soon again. Thank you again.
Thank you. Bye-bye.
Bye-bye. Thank you.